just names.
Bore da bawb, John Williams dwi Cadeirydd Iechyd Cyhoeddus Cymru. Croeso cynnes I cyfarfod y bwrdd cyntaf y flwyddyn. Croeso mawr I ein ystylwyr ni. Mae'n dda cael eich cwmni bore yma. Croeso arbennig I Hannah Lindsay a Sarah Morgan gyda ni ar gyfer eitem 3 ar yr agenda. Y bwrdd yw corff llywodraethu Iechyd Cyhoeddus Cymru, ac mae gennym etiquette bwrdd ffurfiol gallwch weld hwn ar-lein. Mae'r bwrdd hefyd yn canol gwerthoedd Iechyd Cyhoeddus Cymru, cydweithio gan barchu ac ymddiried yn ein gilydd I wneud gwahaniaeth. Good morning, everyone. I'm Jan Williams, the Chair of Public Health Wales, and a warm welcome to today's board meeting, the first of the year. A big welcome to those joining us online. We're very grateful for your time this morning, and it's good to have you with us. And we send a special welcome to Hannah Lindsay and Sarah Morgan, who are joining us for important item 3 on our agenda. The board is the governing body of Public Health Wales and works to a formal etiquette that you can find on our website. The board also practices and applies the values of Public Health Wales, working together with trust and respect to make a difference. Now, as the governing body, the board has a specific role and responsibilities. The board sets strategic direction, builds and sustains strategic partnerships, sets the risk appetite for the organisation and oversees strategic risks, and oversees and scrutinises delivery against in-year plans. The board also is responsible for setting the tone and culture of the organisation. On the last point, the board is committed to promoting a learning culture in which, when mistakes happen, we apologise, we set about putting things right, and we look to improve for the future. We are engaged in such a learning exercise now, after the well-publicised issues around a service-led change to cervical screening intervals. The board adds its apologies wholeheartedly for the anxiety and the concern that this has caused, and Tracy's Chief Executive report will say more about what we're doing to put things right. The board is also determined to ensure that all members of staff can come to work and be their best authentic selves without fear of discrimination or disadvantage of any kind. And in that context, we are delighted to be signing the pledge of zero tolerance of racism. Goddef garwch zero an erbyn hiliaeth. As we remain in the throes of the pandemic, we are continuing to focus the board agendas on those matters that require ongoing oversight to ensure good governance. Tracy's Chief Executive report will give us an overview of a number of key activities, both in our role as a trust and as the National Public Health Institute for Wales. And the section on the board assurance framework will, as ever, give the board all the information it needs to ensure effective oversight and scrutiny of the 2021-22 operational plan. And then that section concludes with the important updates on COVID-19 and the winter response plan. The board has 5 committees and they discharge specific governance and leadership roles on behalf of the full board. And at every meeting, we receive updates on the work of the committees from the committee chairs, and they bring to the full board's attention any matters of concern. The section to note includes a new item this month, and it's a synopsis of the matters the board considered in private session in November. The board has a protocol for considering matters in private, and that can be found on our website. This is the first iteration of such a report, and it will be refined at each meeting, and I'm grateful for the feedback from Verity Wynne of Audit Wales on how I can improve for the March meeting. So gan na drot our agenda, Oes yma ymddiheuriadau, please, Liz? So we'll turn to the agenda, and do we have any apologies for absence, please, Liz?
Yes, because we have Helen Bushell, the Board Secretary, Claire Sullivan, who is our Unite representative on the board, and we have apologies from Ian Bell for lateness.
Diolch yn fawr. So, datganau buddiannau, please, do we have any declarations of interest other than those already set out in our declaration of interest, which you can find online? No? So thank you. So with that, as I said, we will move to this important agenda item 3. And Neil, am I handing over to you?
Diolch, Jan. Good morning, everyone. Neil Lewis, Director of People and OD. Delighted to bring this pledge to board today for sign-off. Just some brief background, Jan, if I can. Colleagues will be aware that obviously in terms of the Race Council Cymru, they have set up an online pledge. This is for organisations and individuals to sign. This is something we've discussed at the business exec team, but also the BAME staff network meeting in November, where this received unanimous support in terms of the sign-off. Supporting this pledge and signing this would really, I think, build on the work that we're doing around the cultural competence certification scheme, where board members will be aware we were recently awarded the silver level for this scheme, and will really build on the work that we're doing at the moment and continuing to do around our HR policies, our training, our recruitment, communications, and the work with our staff networks. What we're proposing today, subject to board agreement, is we would then look to sign this pledge outside of the board meeting later this afternoon, and suitable communications would then be issued as a result of signing this pledge. Just one area just to pick up just around the monitoring of this. I think colleagues had raised the point around how we would sort of monitor via staff surveys, etc. I just wanted to give, Jan, if I can, just that reassurance that we do ask specific questions within our own internal staff surveys, but also the wider NHS staff survey around any forms of bullying, harassment, and we are able to report on that by protected characteristics. So that is something that we can do, we are doing, and will continue to do in that space. Finally, just in terms of Annex 1 then, that just sets out within the documentation our Public Health Wales statement of intent in this space, and the work, as I say, and the monitoring practices that are ongoing. The document obviously sets out as well the work that we're doing as an organisation and continue to do, but it's brought today to board for approval for us to sign this pledge later today. So I'll pause at that point and happy to take any questions, Jan.
Diolch yn fawr, Neil. Before I open it up, croeso eto Hannah, Sarah. Welcome again, Hannah and Sarah. Is there anything that either of you would like to add, please, before board members comment?
I'd like to just say I'm really pleased to see that the organisation is going to sign this pledge today. It really fits with our values, and it really sets out our very clear intent of being an inclusive organisation where everyone can be their best. So it's really good news. Thank you.
Thank you. Diolch, Sarah. And Hannah is the co-chair of our BAME staff network. So Hannah, lovely to have you with us.
Thank you, Jan. Yes, really pleased that we're signing this. We're hoping to sign this today. I think it shows our ongoing commitment for zero tolerance around racism going forward. It's an ongoing task, and it shows the journey that we're on in trying to tackle that. Thank you.
And our grateful thanks to the network for all the preparatory work that you've put into this, and also that Sarah's put into it as well. So can I open it up then, colleagues? Are there any comments, questions or points that you'd like to make on this? No, I think it's all. Tracy, would you like to come in there?
Diolch, Jan. Yes, please, if I may, just to echo your thanks to Hannah, to Sharmila as well, who's not with us as co-chair of our BAME network, and Sarah and Neil on this. I think it's just fundamental for us to do this. I think it's a real opportunity for us to embed the conversation and make sure that we are talking about this across the organisation, so it really becomes part of our culture, so that everyone can, be themselves at work without any discrimination whatsoever. We're talking about race today, but we could talk about it across all protected characteristics. So just a really big thanks, really important. And we were going to stimulate me pressing the button, and we thought no doubt technology would be disastrous, so we will be clicking to sign up to the pledge later today. So just a really big thanks, and really, really important for us.
Thank you very much, Tracy. And Mohammed, you'd like to come in, please.
Thank you, Jan, and thank you, Neil and Sarah and Hannah. Just to add my support as well, I think this is a fantastic thing for us to be doing. It's a very, very strong pledge right at the top of our agenda, and I think it is doing a growing reputation for valuing diversity, equality, inclusion, world of good, and it's absolutely the right thing to do. On the point of monitoring, Neil, I wonder if we can think about how to bring those surveys to the People and Organisational Development Committee, so the board members can be engaged with the monitoring as well. Perhaps we can pick that up outside the meeting. But great stuff.
Absolutely, Jan, if I can just quickly pick up on Mohammed's point there. So at the next People and OD committee in February, we've got the high level breakdown, Mohammed, in terms of our latest wellbeing survey. What we'll then look to do is, as part of the sort of work that's ongoing there, is to then break this down for a future meeting as well. So we will be able to get into that space to break this down by those protected characteristics.
Thank you. And I know, Diane, you were interested in how we were going to ensure that we embedded this pledge. Is there anything that you want to add to Mohammed's comments?
Yes, please, Jan, if I may. Diane Crone, Non-Executive Director representing the university sector. Yeah, I echo everybody's comments. This is really, really good and representative of the ethos of the organisation. I just wondered, Neil, with the monitoring, whether it would be an idea to embed a question in the staff survey around how staff perceived the organisation, as you develop this over the coming months and years. So that was just a comment, really.
Yeah, absolutely. Thanks, Dan. It is a really good point. We do ask a specific question as part of our internal survey, but also as part of the wider NHS survey at the moment. There is an opportunity. Obviously, we're continuously reviewing our surveys and content, so we will take that comment on board, Dan, and there are a number of working groups that have now been established for the national survey, and again we will feed those points in as part of those discussions as well. So thank you very much, Dan. Really useful comment.
Thank you, Diane. And I know all of the non-executive members of the board are really supportive and really think this is a huge step forward, and Judy Rees, our non-executive director, Kate Eden, our vice chair, all signalling, as I know David Edwards, another non-executive director, will as well. So there's unanimous support from the board, because we know the executive director colleagues had already looked at this. So the board is happy to approve the signing of the Zero Racism Pledge later today. So, and Sian Griffiths has just come in as well, so that's a full set of our non-executive directors. And Tracy and I will sign it on behalf of the organisation later, and then we will remit to People and Organisation Development Committee, Mohammed and Neil, the best way to monitor how this is being embedded and the best way we can track that. Is that okay? Thank you.
Jan.
And diolch yn fawr eto. Thanks again, Hannah and Sarah. Lovely to have you with us today. So we're turning now to the Chief Executive's report, which starts off our Board Assurance Framework section. Tracy, drosodd i chi, over to you.
Everybody, Tracy Goodman, Chief Executive. There's quite a lot to cover on the Chief Executive report today, and I'll take it mainly as read, but just highlight a couple of areas. And if Ian Bell joins us over the next few minutes, I'm going to ask Ian as well to give us an update on some emerging findings around treatments for COVID. So, Jan, you mentioned earlier in your introductory remarks around cervical screening. So people who are watching may or may not be aware that we announced changes to our cervical screening programme at the beginning of January, and these are changes that had been recommended by the National Screening Committee, which is a UK-wide screening committee, following an evidence review of looking at the most effective and safe approach for screening, cervical screening for women and for people with the cervix, now that we've got the papillomavirus screening in place. Scotland implemented those changes in 2020, and the Welsh Government, having considered those recommendations, also made the decision to implement them. These came into effect in January. Unfortunately, when we were announcing it in January, there's a lot of anguish and concern from people, and we hadn't quite anticipated that, to be honest, but clearly we could have explained the changes in a better way, and we fully recognise that. And as you said at the beginning, we really apologise for any avoidable distress and undue distress that the announcement may have triggered. But what's important now is obviously we'll learn from it, and we are developing a range of information products that can really help explain those changes better, and it'll inform how we announce similar changes in future, not just for screening programs, but across all of our functions. So that's really important. And I'm going to hand over to Maine, who's our National Director for Health Protection and Screening Services and our Exec Medical Director. And I know Maine will want to add a bit to that, Jan, if that's okay. So thank you, Maine.
Maine.
Diolch, bore da, Jan and Tracy. Thank you. Meng Kaur, I'm the National Director for Health Protection and Screening Services. It was very unfortunate with the message landing in the way that it did, and we totally understand the anxiety that it caused and are sorry for the incident. I think one thing we've learned is that we need to take stock on the response that we had, and we will be developing campaign materials, and I know the team is working very hard with the relevant charities to see how we can develop those materials so that they are the most appropriate for the people who have cervical screening. So that's in progress, and we hope to have more detail about that towards the end of January. We are also undertaking a learning exercise, and we have a debrief session planned in the near future to really understand what we can do better when we have announcements like this in future. So thank you.
Yeah.
Thank you, Jan. If I just carry on through the report, thank you, Mayor. I'm sure board colleagues may have some comments and questions. So, Jan, you and I and Meng joined us for 2 meetings with the Minister. We've had some really constructive meetings with Minister of Health and Social Services recently. In fact, I had 2 last week with her, and also with the Minister for Finance and Local Government just before Christmas, and the meeting with the Minister for Finance and Local Government is part of our series of meeting with all Cabinet Ministers as we do during the course of the year, which we've commenced, and we've updated on this previously. I think our reflections would be that with COVID, one of the interesting realisations, I think, for many people with COVID as a result of the pandemic, is that public health is about everything and anything, and everything's connected to everything. So it's been very much in the context of those conversations with ministerial colleagues. And similarly, we had really constructive meetings, the first introductory meetings with the chair of the Health and Social Care Committee, which we previously reported on before Christmas, but more recently with the chair of the Children, Young People and Education Senate committees. And then I've included in the report 2 submissions to the Health and Social Care Committee that we were asked to provide, and have attached the appendices for those. And obviously very happy if board members have any comments. I was just going to ask Ian Bell, our National Director for Public Health Data Knowledge and Research, just to update on some emerging trials. I'm not sure Ian has joined us yet. I know he's on a government meeting at the moment. So I suggest, if he hasn't, I won't be able to do justice to it, Jan, but I wonder whether we could bring it in the next item around winter response, and I'm sure Ian will have joined us by then, if that's okay. So I'm happy to take any questions. I'm sure all exec colleagues would be as well.
Thank you, Tracy. Covered a lot of ground there, and perhaps I could just comment before I open it up on the fantastic work from our Pengu team. We've set that out really well there in the report, and obviously the board would want to congratulate them on everything that they're doing. So Judy, David, Kate, and then Sian. So Judy, bore da.
Diolch, Sian, bore da. Judy Rees, Non-Executive Director. I'd just like to comment really in terms of the third sector perspective on the first item, and I think, you know, from a Public Health Wales point of view, you know, clearly the apologies have been made and they've been heard, and I think the really important thing was in Jan's opening remarks about, you know, we will learn from this, and I think that's the really important thing. But I guess from a third sector perspective, and from the cancer charities, it's really you know, that we actually did welcome this change, and I think perhaps that has got lost a little bit, you know, in all the sort of the hoo-ha and around the communication. That it is actually a good news story, and I think it's important to say that, you know, the cancer charities will want very much to work with Public Health Wales in order to get that message across. So I think that's an important point to make. Thanks.
Thank you, Judy, and your support, and from Tenebus, from Macmillan, from CR UK, from Joe's Trust, were tremendous actually, because the importance and the improvements this will bring, as you say, kind of got lost in the maelstrom of the moment, didn't it? And so just thank you very much for your support, and I know Meng and the team will be looking to build those relationships even further. Actually, I mean, it coincided with Cancer Awareness Week as well, didn't it? So, you know, it was a particularly hot topic, but there's a lot for us to do in many countries, including Wales, around preventing and treating cancer. So yes, thank you for your support, and just look forward to working more closely with you.
Thank you. David, you'd like to come in next. Bore da.
Diolch yn fawr i Jan, bore da. David Edwards, cyfarwyddwr anweithredol, Non-Executive Director. If I can first thank Tracy for her report and for the work she's undertaken as outlined in the report, and just pick up on the cervical screening and Meng's remarks as well. I think one thing strangely positive from the pandemic is the heightened public awareness of health issues. I think that is something that we can build on, and maybe was reflected in the public reaction to this actually. So I think there's a plus for us in this. One of the pluses is that there is an opportunity to engage early with the public on health issues and try and develop that dialogue that creates confidence and allows us to have a really positive relationship with service users and the public at large, because I think the public have moved on considerably during the pandemic in terms of awareness of health issues, as much of the work that Mark has been leading on has demonstrated to us as well. So just wanted to note that. Diolch yn fawr.
Yeah, David, thank you very much. Ian has joined us, but what I propose is that we'll take questions and comments from non-executives now and then return to Ian at the end, if that's okay. So Kate, bore da, dros i chi.
Bore da, diolch Jan. Kate Eden ydw i, cadeirydd, cadeirydd Pwyllgor Ansawdd Diogelwch y Gwella. Kate Eden, Vice Chair and Chair of the Quality, Safety and Improvement Committee. As I thought he would do, David has probably covered most of the points that I was going to make. But I think we've talked at the board here, haven't we, in the past recent months around it being a teachable moment for public health messaging currently, and I think that's what we've seen over the past couple of weeks with this groundswell of interest and understanding in some of our screening programmes. And as chair of QSIC, we'll be looking at how we engage with service users and refreshing our approach to service user engagement over the coming months, and we'll be overseeing that work through the committee. And I think there's considerable work that we can learn from throughout this, in the way in which not just how we consider how things are going to land as we announce them, but the work we do with service users and the third sector before we announce things, so that we really understand our public and the way things are going to land with the people that we serve. So just wanted to make that point to build on from David's there. Diolch yn fawr.
Thanks, Kate. And if I can add, I know Rhiannon and Mark had what sounds like an exciting conversation yesterday about how we engage with the public more broadly. And I don't know if Rhiannon may, she just popped up on a video, may just want to say a word on that, because I think that's some really exciting developments about how we build David's, Judy's and Kate's point actually. So Rhiannon, did you just want to say a couple of words on that?
Yeah, well, really exciting opportunity. I think now organisationally we really want to be in this space. We want to be much more proactive in terms of our work with service users, third sector. We were talking yesterday potentially about how we mobilise and get interest, I guess, from the youngest possible people in our nation, i.e., you know, those that are perhaps actively involved with things like brownies, guides, and getting them interested in their health and public health. So yeah, watch this space. That is definitely an area that we want to take forward. And I think the other thing to say, we've also got now, for the first time, a digital system to help us be proactive and reactive in collecting and gathering data. So that's the other bit that goes alongside. Thanks. Yeah.
Thank you, Rhiannon. That sounds a really interesting development. We look forward to hearing more about that. Sean, I think you wanted to move us on to the UK and the EU.
Diolch, Jan. Yes, I did. Sean Griffiths, Non-Executive Director, Particular Responsibilities in Public Health, and also the new CRIT Committee. I think, Tracy, I was really pleased to see that paper that you submitted on the Provisional Common Framework, because I think what it showed was what a strong role Public Health Wales has in the global space, not just in Europe, but obviously taking a lead role in Europe. And I thought it was really interesting to pull out the global as well as the European and the separateness. And I'd really like to see that theme developed a bit more, because as you also have in your paper about the genomics work, I mean, that's globally recognised as excellent work. So I think I just wanted to commend the organisation for that particular stream of work and say I hope that we can see that taken forward and supported. My other comment would be that it's great that there's a UK Health Protection Committee, but with the separation, and I'm sure you know what I'm going to say, with the separation with of health, the health promotion, health improvement, inequalities arm away from the health protection arm, I just wondered whether there was any move towards a UK committee across those aspects of the broader public health agenda.
Thanks, Sean. And Meng may want to come in as well. I mean, it's interesting. Before we submitted the final comments around the common framework that we did jointly with Welsh Government colleagues, obviously we work very closely with them, we did specifically want some changes around reference to global health, just to recognise that we're very active, particularly through our WHO Collaboration Centre, led by Mark, but also with our IANFI, as the International Association of National Public Health Institutes, which isn't the most snappiest title, but we have a really important role to play. And as you say, our PENGO, or Pathogen Genomics World Leading, opportunities there for research, for innovation are huge. So we specifically wanted those changes because it felt very England focused otherwise, to be honest, on the global stage. So yes, I think the health protection is a very easily, clearly demarcated activity. And obviously in England, it is separated structurally as well, with the UK or England Health Security Agency looking at health protection, and of course there's the Office of I can't remember the name.
Health and disparities. Health improvement and disparities.
And disparities. Thank you. I think that still finding its feet. So I think it's a really important point. Before COVID, we had a number of 4 nations, sometimes 5, including the Republic of Ireland, looking at health inequalities, looking at health improvement. So we already had pre-existing structures, and I think you're right, we need to dust those off and look at perhaps a broader population health impact, a UK committee. I think it would need to be positioned very carefully, just to make sure that it gives effect to, from an equal basis across all of the devolved nations, and I mean England, Wales, Northern Ireland and Scotland as devolved for health. So, but I'm sure Meng may want to say something.
Yeah, thank you, Tracy. So I think, you know, if I draw a parallel with mental health and the parity of esteem, I think there needs to be a parity issue here. So I recently took part in a global a debate on COVID response. It was to compare and contrast UK and Thailand initiatives, and the narrative that I took to the table on Wales was very different to the narrative from England. So I think from that point of view, we have to recognise that we are a national system. We make our own decisions. There's a separate Welsh government, and that clearly guides our policy decisions as well. So I think we have a contribution to make in the global arena.
Thank you.
Okay, thank you very much, Meg. Mohammed, did you want to come in there?
Not on that issue, Jan.
Okay, thank you. So you wanted to pick, we've included the strategic risks in the agenda papers today, so the directors can refer to them as appropriate as we go through the agenda. So Mohammed, you'll keep your question when we get to the relevant agenda item. Okay, so thank you all. And Ian, lovely to have you with us. You've been able to join us now from your Welsh Government meeting. And obviously we reported recently on our involvement in a new drug trial, and the board's very interested in that. So perhaps you could give us an update, please, Borda.
Yeah, thanks, Jan, and sorry for being a little late here. So the work here was building on our work on the vaccine trials, where we've worked in partnership with Health and Care Research Wales to act as a national coordinator to ensure Wales can take a whole Wales approach to COVID-19 vaccines. And just before Christmas, the design through Oxford was expanded into antivirals through a platform trial called Panoramic. And what the programme enables you to do is quickly set up and evaluate the impact of antivirals on COVID-19. So the first one of which is monocuprivular, I think it is, and my pronunciation of drug names is not the best, so apologies. And that one is now live with 4 GPs under contract and over 600 people already signed up into it. And I think this is an important development for us into how do we begin to think strategically about how we take the work about rapid involvement and rapid deployment of vaccine trials and now antiviral trials beyond the pandemic. And we're currently doing some strategic work around what the future is for this bit of work and how we might like to look at it. But that's the background for it, and hopefully that answers the questions.
Thank you very much, Ian. Sean, this was something that you were particularly interested in. Is there anything you want to ask Ian at this point?
Not at this point. Thank you very much. I think the next CRIC agenda will be looking in more detail at how we keep this sort of work ongoing. So perhaps at a future board meeting we'll report back a little bit more. But thank Ian very much for finding out how all of that works for us. Thank you.
Thank you, Sean. And I think that concludes the discussions in respect of Tracy's Chief Executive's report. So thank you again, Diolch yn fawr eto, Tracy. And we move now then to Meng on the very important COVID-19 update and winter response plan. Drosodd i chi, Meng. Over to you, please.
Oh, diolch, Jan. So I thought I would share some slides which I've prepared to inform this update. So I just want to check whether people can see the slides.
Yep.
Thank you very much. So thank you for the opportunity to give an update on COVID, and I'm also going to take the opportunity to give an update on non-COVID and the other incidents and outbreaks that our team are also responding to. So some high-level summary notes, just to say that the 7-day incidence rates continues to decrease. and the latest is at around 500 per 100,000, and this is down from the previous 7 days. The test positivity rate, which is a good marker of the level of infection, has been quite high, but it's on its way down, and it's now at 34%. Omicron, as we will see later, remains the dominant variant in Wales, and there's some emerging vaccine effectiveness studies suggesting that there is waning immunity against symptomatic infection, but better protection against severe illness resulting in hospital admissions. From a hospital admission and admission to critical care point of view, the numbers of cases have increased slightly in most recent weeks, but I'll show you some data later to give some assurance about the trends in the long term. The all-cause deaths have decreased in the most recent week, but they do remain over the 5-year average. There are some early signals that we are seeing increasing numbers amongst children, particularly school children, and reports of incidents and outbreaks relating to school settings from our local teams. So when you look at the epidemiological curve, looking at the numbers of cases in recent months, you will see that there was a peak over the Christmas and New Year period, which quickly subsided to the current levels in the latest data. Now, we can't easily predict how this will pan out over the next few weeks, but we hope that it will remain at the current low levels. When we look at the variants that we are continuing to detect, the yellow bar shows how dominant Omicron currently is, compared with the dark blue bars, which is Delta, and you'll know Delta essentially dominated the best part of last year, but it's pretty much completely replaced by Omicron, which now accounts for over 95% of cases. You look at the distribution by health board area, you will see very little difference in the rates between, but with Powys having the lowest rates and Iron Bevan having the highest rates in the previous 7 days. You look at the breakdown by age, you will note the sharp decrease in the 17 to 49-year-olds, which is the light blue line and the yellow line on the top. But if you look at the line which is the 0 to 16s, which is the dark blue line here, you will see that there is a slight increase, and this may well continue given that much of that age group isn't protected by vaccination. So it's not unexpected, but it's a trend that we need to watch carefully. When we look at hospital admissions, as I reported earlier, the overall trend is slightly increased, but you will see that, you know, these trends are very minor compared with previous waves of the pandemic. And you will see that the rates of hospital admissions are low. And considering we've got high numbers, that means that the proportion of cases that are going to hospital is very much reduced compared with the previous waves of the pandemic. The number of deaths continue to fluctuate on a daily basis, and of course there's going to be a lag between the peak of cases and the reported deaths, but it's worth noting the decreasing trend in deaths. Vaccination continues to be the key preventive measure for COVID and transmission, and we can see the very high uptake rates where 91% of the population of over 12-year-olds have had 1 dose, 86% 2 doses, and 66% have had the booster vaccine, and around 1.8 million doses of the booster have now been administered. And the breakdown that you can see here are by the various groups, noting the high uptake rates in most of the most at-risk groups. Looking at the delivery of vaccine, just to note the incredible pace in which the booster vaccine has been delivered since it started in September. And clearly, you know, this is in line with the JCVI recommendations about vaccination programs, and I thought it would be useful for the board to be cited on how we deliver the program by age groups. And this slide summarizes the individuals who are not at greater risk of serious disease, so they don't have risk factors, and this is the vaccination schedule. And also the impact of recent infection on how long they have to wait before they receive the vaccine. And then the next slide is those who are at risk and the eligibility for vaccines. So future development is to look at the vaccination of 5 to 11-year-olds who are at greater risk of severe disease, and that started in Wales last week. But for those who don't have at-risk factors, we are waiting for further advice from JCVI on this group of children, and we're waiting for further data and evidence to inform that decision. So some of the key challenges are really around determining the future vaccination program. In view of the waning immunity, we clearly need to consider that as to whether the frequency of the vaccination program should be more than once a year. And I think the evidence is suggesting that. There clearly needs to be catch-up campaigns, and that's determined by the variants that are circulating. And there's an opportunity to learn from our experience and transfer some of that learning to other programs of vaccination. And one of the things we need now to focus on is to look at reducing risk and inequalities in vaccine uptake. We do have information suggesting that vaccine uptake is, not as good as we want it for certain groups. So we will continue to work to address those inequalities. Colleagues will be aware that we're reverting to alert level 0 in Wales from tomorrow, which means that along this transition, we've now had no limits to numbers attending external events outdoors. We've also reduced the self-isolation period to 5 days for cases of COVID, and that's subject to 2 LFD negative tests. Nightclubs are to reopen tomorrow and hospitality will operate normally. The COVID pass will continue to be a requirement for large events and specified venues, and the use of face masks in schools will continue until after the February half term, when local flexibilities will be determined by a risk assessment done by the incident management teams. There will be a reversion to a 3-week cycle of decision making in Welsh Government from the 10th of February as well. I thought I'd start looking at what's ahead of us in terms of other respiratory threats that are not COVID, and we continue to report the surveillance of this, and you will see in this chart that the grey bar is COVID, but how that compares with other diseases that we monitor is that it remains the highest burden of infectious disease and respiratory infections. But the other signals are from rhinovirus, which is the common cold. Generally, people aren't tested, but these are from our routine multiplex testing outputs. And you will note from the chart that the red, which is influenza A, and the yellow, which is influenza B, don't feature. So we're not picking up signals of influenza, but what we are expecting is that there could be a wave of influenza coming our way, which is starting to be reported in continental Europe. So what other incidents and outbreaks are we dealing with? So we continue to monitor these, and certainly tuberculosis remains very high on the list. We have a number of clusters and incidents that we are investigating. The board will be aware of the Llwynhendy outbreak of TB that's been ongoing since 2010, and in the September board meeting we approved and agreed to undertake an external independent review, which is ongoing, and that's by far the largest cluster. But we also have had reports of cases where we've screened individuals to identify whether there's any further transmission. And, you know, some of these are in education settings where there is a susceptible and vulnerable population. We continue to have outbreaks of gastrointestinal disease, so E. coli 0157, which is clearly of concern with the potential to cause great harm, but the incidents that we currently have are limited to 1 or 2 cases. We've also had a report of Salmonella typhimurium resulting from a food source and also certain food preparation practices that we're continuing to investigate. As I mentioned earlier, flu is circulating in continental Europe, and we need to focus on prevention and vaccination going forward. Coming to my last slide, I think Public Health Wales continues to be in normal response, and we have a clear and effective governance process to bring people together to get a situational report and also to provide specialist advice to Welsh Government to inform policy decisions. In response to Omicron, we needed to identify surge capacity for our health protection team, and clearly this relates to strategic risk 1, which is included in the papers, and this is our risk of the ability to sustain our health protection response. I'm going to hand over to Neil just to give us an update on where we are with the mitigation on the health protection response and the surge capacity that we've been able to mobilise across the organisation. So Neil, can I ask you to give us an update on this?
Thanks, Meng. So I think as Meng's highlighted, we are still well and truly in that sort of space where we're looking at ensuring we've got sufficient levels of resource. So lots of work has happened behind the scenes with exec colleagues to make sure we can identify individuals should we need to surge at appropriate times. So we do have groups of individuals, consultants, nurses, admin resource that we are able to call upon at short notice should there be a requirement to bring in additional resources to cover for COVID absence, sickness absence. That has worked very well so far. An induction programme is in place for individuals to ensure they've got the right level of knowledge, experience, and in terms of that process which has been established within Meng's team, that has, as I say, been tried, tested, and is working very well at this point. We will continue to monitor, obviously, as we need to, and I'll be talking around the levels of sickness absence as part of a further update as we move through the agenda. But as I say, just to give that assurance, we do have a group of staff that we are able to call upon at the appropriate time as part of this process.
Oh, thank you, Neil, for that update. So we are reviewing the risk and we will be proposing a revision of the risk score accordingly. So my final point is just to move to look to the future, to an end state where COVID is an endemic. And by endemic, it doesn't necessarily mean we don't have any coronavirus and COVID, but we are at levels that are manageable and predictable. So we're developing a framework for the communicable disease control and the response in that end state, and we are developing the detail around that, which I'm very happy to update at a later stage. Thank you.
Diolch yn fawr am eich ddiweddariad poesg, Meng. Thank you very much for that important update, Meng, and to Neil. So I know that we have 2 colleagues who want to come in, Sian and then Mohammed. Sian, please.
Thank you, Jan, and thank you, Meng, and thank you, Neil. I'm reassured that we are looking at this with the due seriousness that it deserves, because this is not going to go away. And I suppose, apart from saying thanks for all the science and for the updates, one thing I just wanted to check on the updates actually was the booster. Did you say we might expect to have 2 boosters a year, or did you, is that where the sciences might take us, or did you say we'll definitely have a booster? I wasn't quite sure what you were saying then. Sorry, I was trying to absorb everything. So what's the simple message on boosters?
course. So, you know, the vaccine effectiveness studies that are reported for Omicron suggests that there's antibody waning at 20 weeks. Now, that's, you know, waning to very, very low levels of immunity against symptomatic infection. However, protection against hospital admissions and severe clinical disease is much better and wanes less rapidly. So I think given that we've only had, what, 3 or 4 months of the booster, the jury is still out as to the sustained response of our current program against Omicron. And let's not forget, this is the evidence on Omicron. Well, if another variant comes through, then we need to consider that fresh. But given the evidence that we have on Omicron, I predict that we will have more frequent booster campaigns than we have for flu, which is done annually.
The reason I wanted to just pull that out was that I think it's an important when we look at the workforce, and you talked about surge capacity, and you talked about maybe extending to school children, because I know that the younger ones, school children, primary school children. So all I'm just trying to flag up the need for resource here, you know, that we need to be assured that we can respond appropriately as an organisation, as obviously part of the whole Wales response, but as an organisation, and just to not feel that that it's all gone away, because there is a sort of tendency particularly in England at the moment to think, oh, it's all gone away, whereas I know Wales has kept in place, you know, and rightly so in my mind, some more measures, but it isn't going to all go away. We're going to be planning for boosters, we're going to be planning for vulnerable people to be looked after, we're going to be planning for children. So I think just to flag up that, and the very important need for surge capacity, which is a lesson I think we need to learn from this time round. So that was really the essence of my point, but thanks for a really good update.
Thank you, Meg. Mohammed, you'd like to come in there, please.
Thank you, Jan, and thank you, Meng. Can I ask 2 questions, Jan? I have a question for Meng and a question for Neil. Meng, can I ask a layperson's question on the science? I was very interested in your graph showing the different variants that have come and gone. And what struck me was that a variant sort of comes along, it peaks, and then it wanes and it goes. It doesn't make a comeback. It seems not to make a comeback. Once a variant has been, we have a different variant. And the one we now have is on the wane and is going. So a layperson might think that there isn't an urgency about vaccinations anymore. And I just thought I'd give you the opportunity to say why that's not true. Because you're just looking at it, it looks like, well, we're out of the woods. These guys aren't going to come back. We don't know what's going to come. When it comes, we'll worry about it. Why maintain the vaccination campaign in the light of that evidence? And then for Neil, first of all, it's really good to see how strategic risk register is being used in the work of colleagues like Meng. So it's really good that we're seeing that integrated. But one of those, the very last strategic is AP15. That's about the resilience of business management systems and processes, which is absolutely vital to any organization. But we're saying that that has been put on hold because COVID-19 work has had to dominate, and that's understandable. But can we have a little bit more detail on what, if anything, that has meant, and whether that has created risk around our resilience that we ought to be aware of? Thank you, Jan.
Thank you, Mohammed. An important point there around the way we are now looking to integrate the strategic risk material into the debates every time. So thank you for that. Meng, would you like to answer Mohammed's first question, please?
Well, thank you, Diolch, Jan, and Mohammed, for the question. So it's a really astute observation that, you know, when a variant comes, dominates, takes over, it then goes, and then it's taken over by another variant, and we never see that variant again. And that's certainly our experience so far. That's not to say that will continue to be the experience, because the reality is that Delta, whilst it dominated And I'm just going to take the opportunity to share that slide again, just to demonstrate that whilst Delta dominated in the back end of last year, you will see that there were other variants also coexisting with Delta, whereas Omicron seems to have really swept everything else under the carpet. And this is the kind of unpredictability of variants as they come along, as to whether they truly outcompete and displace completely other variants, or whether they coexist happily with other variants. And I'm not an expert in viruses to know how we get to that population level behavior, but I'm tempted to conclude that this is something about evolution of a virus. This is something about survival of the fittest. And mutations allow viruses and other organisms to outcompete in the way that they can then ensure survival of that variant. So I can't predict what's going to happen in the future, but to your point around vaccination, I think the best time to be protected is when there isn't a virus circulating, so that you've got enough time to build up your immunity. So when the virus comes along, it presents its antigens to the body, and then you've got antibodies that can be mounted in response, that are ready to attack the viruses, because the natural immune response takes, a bit longer to kick in, which is why I think it's really important that we are protected and remain protected through booster vaccinations.
Thank you, Meng. That's a very comprehensive response there. Neil, the second area of Mohammed's question, please.
Thanks, Jan. Thanks, Mohammed. Yeah, so the specific point in terms of AP15 around resilience of systems, that obviously sits within the specific risk within Meng's area. But I think the broad comment I would make, Mohammed, in that space is we are continuing to work tirelessly in terms of systems processes. The call we've had to make around some areas, if I was just to give you a live example, was around sort of rota management system. One of those things clearly requires us to be able to pilot that within those directorates, working with staff, testing. As an example, that is one which we've had to say, look, we need to delay that going into April, purely on the basis of the capacity, the headspace, and really from the sort of feedback from the staff within the area. Quite rightly, as you can imagine, now is not the right time for it. So I think just to give that assurance to the board, we are continuing to develop systems, make improvements in that area. Some of these are purely, Mohammed, just around a timing issue, just for sort of capacity and headspace to be able to effectively engage with the staff and put in place the best and most appropriate systems, really.
Okay, Mohammed.
Great answers, thank you.
Yeah, thank you, Neil. And diolch yn fawr eto, Meng and Neil. Thank you again, Meng and Neil, for those really important updates there. Now we move to item 4.3, which is our integrated performance report. A lot of material in front of the board in this report, and as ever, we take it that board colleagues have read all the material, so we don't ask any lead directors to review really the material that's already there. And Hugh sort of leads us through and choreographs this as ever. So Hugh bore da and drosodd i chi. Good morning, over to you.
Bore da pawb, Hugh George ydw i. Jan, you worry me every board meeting when you say choreograph, because I'm certainly not going to dance it, and I'm not sure I want you to score it either. In terms of the integrated performance report this month, I think we'll do it in the normal way. If I just pick up a few overall comments, I think the feedback from the board in terms of the onward development of work and of this report, you'll notice two things that really I'd like to bring to your attention today in the report. The board expressed concerns back really last autumn in terms of the work level with the pressures of COVID and the expectations of what staff were having to do across the organisation. So I think you'll see in this month's version of the operational plan section of this performance report, the work that we have done, the fact that actually a number of operational plans, targets and milestones have been put back or are being put back in recognition of the fact that we've had to prioritise with the Omicron, we've had to prioritise work. So I just think it's important that people pick that up. We're not seeing that as failure in terms of performance report. We're seeing that recognition of how we've had to work differently. The other thing is, I always talk about this integrated performance report as a sort of a continuous improvement journey, taking feedback from members of the board in terms of improvements as we go on. I think what we're trying to do at the moment is not make a large scale changes on these next couple of months, but we are working, and we've listed here for you a number of the areas that we are looking to make improvements on. And so the version that you'll be seeing going into the new year will be picking up many of those, and I'm hoping those are picking up some of the sort of areas where board members have fed back to us. In addition to that, I think, Jan, you particularly have fed back to us in terms of how we can bring the strategic risks in here. So we're working with Rhiannon's team in terms of a tab for strategic risks, which actually let you drill down to a bit more detail for that. So those things will all be ready for the new year, and I think they'll show us the next version of this. So in normal way today, as I said, as you said, introducing this, I don't think we're going to go through the report in great detail. What we will do, because it's quite a sort of lengthy report, we'll turn to a number of directors in turn, ask them if there's any sort of significant points they'd like to bring up from the report, and then pause and ask if board members have got any questions of them. So I think that tends to work in the past. So the first person I'll turn to is Neil, who will pick up the people and OD issues.
Thanks, Hugh. Just three points for me just to pick up, Jan, if I can. So in terms of the sickness absence data, I suppose I just wanted to give the latest position, just conscious that obviously what is within the report refers to December, and just to give some intelligence around where we're at. So as part of our weekly submission, which we provide to Welsh Government, our sickness absence levels are running at 3.4%. Just for colleagues to be aware, this is obviously lower than this time last year. Some of this is obviously to do with the increase in our headcount and whole time equivalent, but we certainly haven't seen the increase in numbers that we thought may have been the case with the Omicron variant. In terms of COVID related absence, certainly the intelligence from across our directorates are we have a number of staff that have had or currently have COVID, but they've been able to continue to work, so that hasn't had an impact in terms of our levels of sickness absence. We do have 18 staff off sick at the moment as a result of COVID related absence, and there have been some trends certainly across screening and microbiology in terms of some of our levels of sickness absence. But we are continuing to monitor that with exec colleagues and operational leads across the organisation. Just two other points if I can, Jan, just in terms of the EDI developments, in terms of the data set, just to give reassurance to board members that we are about to commence that development work now in February, and the intention is we will complete that by the end of March. So for our board meetings post the end of March, we will then be also reporting on that EDI data to board, and obviously reporting on that to the People and OD committee as well, and using that data as part of our fortnightly business exec team meetings as well. Nothing else, Jan, from my perspective, significant to report in terms of turnover or statutory compliance. They've remained relatively static, as the report highlights. So more than happy to pick up any questions or points of clarity.
Mohammed, you'd like to come in, please.
Thank you, Jan. Just to add to what Neil has said, well, first of all, I think 3.4% seems really very strong, and I think that says a lot about the workforce and the sort of commitment. I expected it to be higher, to be honest, and it's probably lower than any averages in the public sector, and I wouldn't mind betting that it's lower than most places in the private sector as well. So that's much better than I thought we were going to hear. The other thing worth bringing out is we've been talking about the vaccination rate of our frontline staff, and at 94%, significantly above the national average, as it should be, is very good. I think we've probably done as well as we're going to do there. And at 81% boosted, again, significantly above the national average, although clearly we'd still want to see that improve as well. But I just want to acknowledge the work that has been done there, because I know that we had some concerns about the level of vaccinations of frontline staff, and that seems to have been addressed effectively. Thank you.
Thanks, Mohammed. And I think it is testament to the work of Rhiannon's team in terms of really continuing to sort of keep that keep those conversations live. I think to really make that encouragement, and obviously as part of the data we've been able to provide, we have been able to have some targeted conversations in that space, which has seen some significant improvements in compliance. So thank you, Mohammed.
Yeah, Mohammed. Hugh, back to you.
Okay, thank you. So there's no other questions of Neil. I'll pick up on the finance section. I think that the main issue for the board today is an understanding of the work that's needed to actually get us that forecast break even and achieving targets at the year end. So, I mean, just looking at it two elements. One is obviously the revenue position. The detail of the revenue position is in here, but I think what the detail doesn't give you necessarily is a full feeling for the work that's going to have to go on underneath that. There is a considerable challenge because of slippage in year, or because the fact that things have actually started late because of COVID and part of people doing other things. So there is a lot of work going on. Directorates and business managers are working with the finance procurement team on a daily basis, but there's weekly updates. They're managing spending plans through on an item by item basis. So we'll continue to look at that as an exec team. If there continues to be slippage at any stage, we are looking what things can be spent to add value and to relieve pressures for next year or bring work forward for next year. So we are working on that in a great deal of detail. It remains a challenge to get there. We're confident from the work that we've got ongoing that we will get there. We can't afford surprises, and I'm hoping there won't be surprises now. But we are aware that, for example, the board are aware of challenges around stock last year. We're aware that some of those challenges continue, and it's been brought to our attention there may be a small element of stock write-off we need to account for this year. So those are things we'll be picking up over the next couple of weeks in terms of some of the work going forward. The other one, and I know I'm grateful for people raising questions before the meeting in terms of the capital. Clearly, when you look at the capital programme, it's a challenge for us. The figures on the look stark in terms of what remains to be done for the rest of the year. We always expected that, I think, because one of the huge items in the capital programme is obviously the digital mammography within screening, for which we got approval from Welsh Government relatively late. It was in last summer, so we're very grateful for that, especially because of some of the challenges going forward in capital. So we're grateful we've had that approved over a 2-year basis, but there's a lot of work to do to obviously get it spent. So there's a lot of procurement work that's gone on that. But this report was obviously at the 31st of December. We've got 25 days, 26 days of January already gone. So what I can say to the board today is that since this report, an extra £5.3 million has been committed via purchase orders. So a lot of that is that screening mammography, that the tender was completed and that's gone through now. Today, obviously later today in private session, because there's a commercial issue, the board are looking to approve a microbiology purchase for £1.1 million. That will obviously, that is, if the order gets approved today and the order gets placed today, we have guarantees from the company that will be delivered by the year end. We also know that there's £300,000 worth of IT orders, the regular IT updates going through at the moment, so, and some estates issues going through. But I am going through in a bit more detail than normal because I know people had questions about it. There are 2 issues that are still challenging us. So there's about £500,000 worth of spend within the collaborative, some of their big development spend, which obviously we're keeping our eye on, but they're needing to get that through. And there's some issue around some equipment for newborn hearing devices, which are only obviously because of the digital side of those, we need the HCW to be able to prioritise that work before orders are placed, but that's about 100,000. So I think hopefully that gives the board the picture then that yes, it's late and it's going to be a lot of work for people and it's a lot of stress on people, but it will give you the confidence that that is literally changing day by day, and with the majority of it is very much on track now.
Thank you, Hugh. Thank you for that detailed explanation, particularly around the capital spend. I'm sure that colleagues will take a lot of reassurance from that. David, I know that you want to come in because you were referencing earlier in the week the scale of the challenge that Hugh has so ably set out in terms of the break-even position, etc. David, dros y ti, Hugh.
Diolch, Jan. Yes, and diolch you for outlining all the work. And as you say, it is a huge challenge, and I think we do need to appreciate the context that there has been, given the great work around what's the word I'm looking for? I'm trying to think of the translation for all the equipment that has gone through the system, and also the COVID spend. You know, those two items on their own have really increased the flow financially, as it were, and our need to keep a track on expenditure and so on. So really huge pressure, and the additional finance flowing does produce that extra pressure to land in the right place year end, as it were. I think we can also see what we can term as dealing with things in-house, and good practice is the ability for us to move budgets around between departments and so on. That makes absolute sense, and it helps us take an overall approach to the finances of the organisation, not just looking at one area and trying to protect that area, as it were. But I'm just interested, Hugh, if you could just say a little more about that, where there's slippage and underspend, if that's going to affect anything historically, or is it just going to be within this year end, do you think? It's not going to impact on the work in those areas going forward? That, for two reasons. One is that will it put extra pressure because there's an underspend, and secondly, will it change the profile of that area of work, as it were, because the finances have changed? I think that's one of the assurances we're looking for from this report. But again, just a thanks to everyone for the huge effort they're making, and I know they'll be burning midnight oil for the next few weeks. So diolch yn fawr.
Diolch, David. Thank you.
Thank you, David, and that's really helpful, because some of that actually leads into conversations about how we go into next year as well. So it's not an arbitrary process. It's not a reallocation process which isn't done without sort of quite a lot of planning and quite a lot of executive engagement in it. So what we do is a number of moments in time. So really, I think the first major one was at the end of the summer, going into about the end of September time. With directors, we did a major review of budgets. We looked at the forecast spend there, and we had an honest assessment as to where stuff would not be spent according to original plans. Then what we did is we worked as an exec team to say where could it be spent alternatively. So this wasn't anybody making individual decisions. We considered it across the board, and even down to, I think there was one item last week where Mark Bellis had a proposal where he could actually bring some work forward that would help us in terms of the population health work going forward. What we did is very quickly we circulated that proposal to all the execs and asked them to answer within 24 hours whether they were happy for us to go ahead for that. So it still gets approved in very much the way that we would do investments and everything. So I think the other issue is going into next year. We are aware that this has not been a normal yet, and I think you picked up very nicely there two sides of this. We haven't spent where we would normally spend because of slippage, but then we have spent where we wouldn't normally spend, if you get me, with all the COVID expenditure. So if you were to look at our ledgers and our accounts on all basis, they're not good information just to base all our decision making for next year. So the budget strategy which we are working on as the exec team at the moment almost uses next year as a bit of a transition year again. We don't make drastic decisions. We're not looking to, as you said, make permanent decisions about moving funding away from areas. That's part of our replanning exercise. And going into next year, we're at the moment finalising our what we call our allocation letter with Welsh Government. That comes through eventually from the Minister, I think, to Jan and Tracy. We know what's in there really, it's just there's been a few particular issues which Welsh Government are working on, because we were funded out of COVID budgets, not out of normal budgets, for some of the stuff we're doing permanently going forward. So they're working internally to shift that funding for us. So on the revenue side, I think we'll be in a tough position next year, but it'll be okay. We're not looking at major drastic cuts next year to fulfil that budget. But I think a point I should have made a minute ago is our capital programme next year will be tight. And I'll be bringing that to the board formally. But all organisations in Wales this year, next year, have had a 24% cut in their discretionary capital because of the overall position in the public sector in Wales. That is going to take us a bit of rethinking and reprioritising. So again, the exec team are working on that. I went through it with the team this week, and we'll be bringing that back as part of the budget setting, the IMT process through before the 31st of March to you. So sorry, I covered quite a lot there, but hopefully that's picked up your questions, David.
Diolch yn iawn. Diolch.
Okay, if there's nothing else on that section, what I'll do is I'm going to hand over to Meng and then Rhiannon, and I think they'll flow from one to the other. So Meng is going to pick up many of the service delivery issues within screening microbiology, and then flow into Rhiannon. I suggest we do both before we take questions. Rhiannon can pick up some of the issues around the quality side of the agenda.
Oh, thank you very much, Hugh. So the two summary slides for screening services and for healthcare associated infections, and I'll take those in turn. So around screening services, the work continues to recover our programmes from some of the pauses that we introduced to several of our programmes during the pandemic from May to July last year. I think one thing we need to recognise is that screening programmes depends on the whole system working together to put all the procedures and processes in place. And some of these impacts are as a result of health boards not being able to prioritise some of the activities. And I'm going to pick out bowel cancer screening as a particular example. And on page 105 of the board pack, you will see that there is a graph showing the wait times for screening colonoscopy. And this is where when someone is FIT test positive, so on the initial screening test they're found to be positive, they're then suspected to have bowel cancer, and therefore they're referred for colonoscopy. In that case, we expect to have a colonoscopy done within 4 weeks of that referral. Now, the reality here is that last year this figure was around 35%, and in the last reporting period this has dropped down to 2.5%. So the reality is that people are having to wait much longer for their colonoscopies. Now, we've prioritised this work to try and reduce this waiting time, and some of the initial work that we've done have resulted in reduced waiting times in some parts of the country and in some health boards. So we will continue to work with our partners in health boards, and taking stock also of the Chief Medical Officer's support, we've written out to health boards to really ask that they consider this as part of the cancer referral pathway, which it is. So we anticipate we will continue to see an improvement in that over the coming months. For other cancer screening programs, breast cancer screening, the delays have been impacted by unplanned sickness absence amongst our reading staff, so that the assessments are therefore delayed. But the invitations and the flows in our clinics have improved, partly because of the revised guidance around infection prevention and control, allowing more people to come through into our clinics. And cervical cancer screening, you've heard the update earlier about the move towards a 5-year screening using HPV testing, which we are currently implementing, and we're working through the best way of communicating that change to those coming onto the programme in the coming months. Other programs such as the Diabetic eye screening programme, we continue to work to understand how best to deliver the programme in the coming years, and there is a transformation programme that's being initiated, and we look forward to the evaluation that the survey and the interviews that we will take with our stakeholders, our users, our staff will generate hopefully a new way of working. But more immediately, we have put out an initiative to review those at lowest risk using optometry services, and 160 optometrists across the country have taken up this initiative, and we've sent invitations out, and I understand the uptake is very good. So hopefully that will address some of the backlog that we've seen in diabetic eye screening. But the most important thing to do around that is to improve accessibility to venues across Wales. We lost quite a lot of venues as a result of pandemic and repurposing of the existing venues, but we are looking at innovative solutions, looking to third sector and the private sector for these venues. So I'll stop there around screening services, and I'm happy to take any questions around that, but I can move on to healthcare associated infections if there aren't any. So our role in healthcare associated infections is largely a leadership role, and a role where we provide expert advice and support with a dedicated team. So the healthcare associated and antimicrobial resistance team, the HARP program, work with health boards to make sure that the IPC guidance and policy and recommendations are implemented. There are clear standards that are required of health boards. So the metrics that we report here aren't necessarily indicators of our performance, but they are proxy indicators of our leadership in this space. So I'm very happy to take any questions on those two topics.
Thank you. I know that Judy has a question on screening. Shall we take that before we move to Rhiannon?
That's a good idea, yeah.
Thank you. Judy, dros y chi.
Diolch, Jan, and diolch Meng for that presentation on where we are with screening. And I think, you know, it's always the case, isn't it, that public health Wales is so dependent on other parts of the system for this, and I think particularly around the workforce issues that you highlighted. And I think it's fair to say, you know, that we need to remain very concerned about these waits for colonoscopy. So I think that's something that, you know, needs to be very high on our agenda in terms of the improvements around that. But what I would like to say, in light of some of the already the conversations that we had earlier around cervical screening, real congratulations on that, in terms of, you know, we've just about, you know, got rid of that, caught up with that backlog that we had. So I think that's really positive news, and that's really great. But particularly I was interested in what you were saying about those novel approaches to diabetic eye screening. And what I wondered really was whether, you know, you mentioned about the uptake being really good. You know, is this being run as a pilot, or is this likely to be an initiative that will get adopted in the long term? My comment on that really would be that a lot of people who would be coming forward for diabetic eye screening would already have those local relationships with their optometrists, so that might actually increase the take-up. So just like your comments on that, please.
Thank you, Judy.
Thank you, Judy. So it's a really pertinent question, and I think we recognise that actually Wales is punching above its weight in terms of the provision of diabetic eye screening, and that's recognised globally. So I recently spoke to the head of diabetic eye screening from Public Health England, and I used to work with her. And, you know, the comparison that they were drawing across Europe in work that she was doing suggested that actually we've got a good program in place. We've got a coordination, and we've got, you know, good uptake rates. I think we can do better, and we need to explore what other models of delivery there are. You know, I visited 2 or 3 of our diabetic eye screening clinics, and clearly the delivery, the service delivery is really good. But the question I would ask, is it the most efficient? Is it the most effective? Is it the most accessible? So there are practices that we need to get into the detail about, you know, just the capacity and demand modelling to see, well, what is the best use of our resources? And as you say, access is really, really important. And if people already have ongoing, you know, connections with their optometrists, why wouldn't we capitalise on that and use them as our future providers? So I don't want to kind of predict the outcome of the Diabetes Transformation Programme review, but I would imagine that we would come up with several options for us to consider, and those options will have a business case to support the rationale for moving to a new model. But you know, let's just wait for the evaluation to come through and see whether that helps us improve the service going forward.
Thank you, Meg. Can I just ask when we might see that evaluation, please?
So I think the intention, so it's already been initiated. I know Sharon Hillier and the team are already in touch with other experts to look at different options for the roles, and the discovery phase is already in tow under Ian's leadership. So we've initiated it. I think we look forward to something towards the end of this calendar year.
Absolutely. Thank you very much indeed. Thank you.
And Charlotte, you wanted to come in quickly on
just very quickly on. Thanks, Jan. Yes, just on healthcare acquired infections, Meng. I think could I just ask that we keep a close eye on this, and that you could expand a little bit more about our leadership role in the future, because I think this was an area that was progressing and has been adversely impacted by the pandemic, and it's going to be part of an important recovery programme given all the pressures on everybody. So just that's what I wanted to say today. Thanks.
Well, thank you. If I might just come back on that, Sian, it's a useful reminder. And when you look at the metrics, the reality is that the rates are going up of healthcare associated infections, and that is of concern. And the team are aware of that. But clearly, we need to work very closely with our health boards to ensure that they don't continue to go up. And there are now standards that are expected. So I think we've got some opportunities to monitor the performance actively. So I think these metrics should remain, but I just want the board to be aware that these aren't directly the metrics for monitoring our performance in public health Wales.
Okay, I mean, we're ready to move on to the Rhiannon section then.
Bore da, Rhiannon Beaumont-Wood, Executive Director of Quality Nursing and Allied Health Professionals. Just to highlight a couple of things with regards to incidents, I think we can say it's an improving picture. Obviously, we still want to do better, but if we particularly highlight, or if I particularly highlight the table on page 107, screening division, the progress that has been made there in terms of closing old incidents or closing them down, we can see the progress being made there. We're turning our attention with the support that's being given from sort of corporately to the diabetic eye screening programme. But I think it's just important to say it's not without its challenges, and obviously this is about getting the basics right and making sure that we are learning from all of these things. And I say that because obviously there are, you know, extreme pressures in Meng's area in terms of recovery, and also in some instances transforming services. So it is challenging, but we do need to continue to support that. We are implementing it over the next couple of months, the new DATEC system, which should be very beneficial to both our organisations, but it's also been rolled out across NHS Wales as a whole. So we have to close things in order to make sure everything that is moved across appropriately. In terms of nationally reportable incidents, none for this particular reporting period, and the number of complaints you can see there is 4 in this reporting period, so that's reasonably low. The one challenge with the smaller numbers is obviously if one is a little bit slower in terms of the response being sent out, it does impact on the percentage in terms of our performance, I guess, around that. But we are able to achieve at the moment the 100% in terms of acknowledgement, which is what we would want to do. But obviously we will continue to strive to our Public Health Wales target in terms of 30-day turnaround on response. I will just flag that we will expect to see, for us, Public Health Wales, a bit of a higher number in terms of complaints, because some have obviously come in relation to the cervical screening issue. We have had formal complaints. Just then to cite that we've had one new claim in, which we were expecting, and it's a Breast Test Wales claim. So that is being dealt with in terms of legal and risk have been instructed. And probably just over on the risk side, I think it's important to say I am aware that, I think we're all aware, it will be quite timely to revisit our strategic risks as we move perhaps away from the focus around COVID. Doesn't mean it's gone away, but I think it is timely. And obviously that would have been part and parcel of our strategy refresh, but because that is slightly moved along in terms of timeline, I think it's important that we look at the strategic risks again sooner rather than later. So that is a discussion that in the first instance business executive team will be picking up, but of course that's a full board discussion that will need to be had. Thank you. Diolch.
Don't see any questions coming in. Oh, Kate.
Thanks very much, Hugh. Thank you, Rhiannon. Just a very quick comment from me. As you know, we've obviously been tracking the incidents and the time taken to close our incidents closely through the Quality, Safety and Improvement Committee over the past number of years. So it's really good to see these numbers reflected in the dashboard here. Clearly putting additional resource into the concerns team is paying off, and we're able to close down these incidents in a more timely manner. And fantastic that we'll be able to give some of that resource as well through to the diabetic eye screening team as well to support them. I think I would just make the case though, and we make it all the time in QSIC, in that it's not just about closing down the incident in a timely manner, it's about learning from the incidents and identifying any patterns or trends in what's coming through so that the organisation can take steps to move forward and improve upon our current practice. So I just want to get a little bit of reassurance that is being captured in the work that's being done at the moment. Thanks very much. Diolch.
Diolch, Kate. Indeed, we are doing quite a bit of work actually applying a more of a clinical governance lens into the incidents and the triangulation actually of information, very importantly, as you say, on the learning. Also using some of the new skills that some of my team have acquired around improvement methodologies into the way that we're looking and presenting those. What we're still working on is how we then present that back and package it to give it in a very helpful way back to the services and functions to work with them on how they want to then incorporate those into taking things forward. Of course, we're doing it in the dynamic way as well, but I think we're very keen to find a much more kind of consistent approach in terms of the most useful way that people could have that information package. And ultimately, it may well then come into the divisional level dashboard work that Hugh's team is doing. So we're working very sort of closely with colleagues across the range of corporate and service side. I hope that helps, Kate.
Okay. I see there's a couple of questions. Shall I just quickly pick up the operational plan? Because I think David wants a general question, and I think that Mohammed's on the strategic risk. So you'll see the detail in the operational plan performance here. It does still look quite a favourable position, but I think I would draw your attention to the fact that the work that has been going on across the organisation. So on page 132, I think it is, you'll see there in the dashboard, there have been a number of requests for change coming through the process. The leadership team have undertaken a lot of work and fed up to the executive team in terms of looking at all the milestones in their directorates and actually whether staff actually had the resource to be able to do those. And in this difficult time. So a number of those, and I think what we'll see is as we continue to analyse the last quarter, the heavy work around the pandemic has continued into January. There are a lot of milestones in the last quarter that I think that work will continue to be challenging for us. So we'll keep working on that in that way. So if I pause there, and I can see David and Mohammed both want to come in, and then any others, yeah, any final questions?
Diolch yn iawn, Hugh. I think you've set out the report very well, and it's very useful for us to get all those links for us to look at as well. One thing you outlined at the beginning of this section was the context in which we are operating now, and I'm just wondering, this is a bit of a difficult question, almost a bit theoretical, but I wonder what we as a board should be expecting in terms of performance at this moment, in terms of the scrutiny we do, in terms of the challenge and the support we offer to everyone in the organisation. Where are we at? What should we be expecting, and what's the trajectory looking like? You know, and I'm just wondering if we can get that feel, so then we know really how to get the balance between that support and challenge, if you like. Diolch.
If I start, I'm not sure whether Tracy want to come in as well. I think what we've tried to do in the balance of this report is actually focus the board's mind on the challenge of getting to the year end. So we've certainly, in terms of the people side of things, the finance side of things, in terms of what are the outstanding actions to be done. Likewise, I think what we're doing is focusing the operational plan on that level. And in screening, I think what Meg's trying to bring through for us are the critical. So I think us focused on at a board level in terms of those critical things that the execs are bringing forward, I'm hoping is narrowing our focus, because there's so much in this report. I know committees are beginning to review it, but the other thing is that it's not a normal year, as we keep saying. So I think what the executives are trying to do at the moment is bring to you the critical things that, yeah, I mean, I can pick any of those, but yeah, what does screening recovery mean? Yeah, what does that mean to year end? Yeah, so I'm hoping that's what, yeah, I think, yeah, one of the things, we've given you all the detail in the report. I know people spend hours and hours looking at the whole detail of that, and I'm working on the basis that if board members have concerns around scrutiny assurance, that we are not picking up, when we summarise the top 3 issues or whatever, if we're not picking those issues up, then we're completely transparent. I'm hoping people will challenge us on those as we go through.
If I can add to Hugh's comments, thanks Hugh. Yeah, maybe just to remind colleagues that actually up until until June of last year, we were pretty much whole scale mobilised into the response, and it was only from January gradually that we were able to start to release staff back into our other public health functions, and some remained in the response, some have still remained or have been mobilised, some remained certainly up until October as well. So this isn't a full year operational plan performance either. So that said, I think the organisation, I mean, it's very rare for me to say this, because it's probably not right for it to come out of my mouth, but I think our people have just been phenomenal in what they've delivered, given that it's a year of 2 halves, and I know we haven't finished the year yet, but so, and we continually ask colleagues, look, if you need to change the milestones here, then do that. We did it quite forcefully at the mid-year review, and have continued to do so as an executive. So I would put that caveat. I think secondly, people are still exhausted. I mean, there is just an accrued fatigue that there isn't really any let-up, or hasn't really been any let-up. I mean, we can consider a little bit of hope that perhaps this year may be slightly less tumultuous than the last year was. But of course, like every public servant, our people are dealing with their own family issues of the unpredictability of COVID as well as work. So we need to be really mindful of that, and I'm not sure, you can never tell whether you've actually got that balance right. But we have tried to ask people to take a little bit of pressure off the accelerator, and that said, they've still done phenomenally. So I think we'll come to the year end, going into the next financial year. I feel that our people have achieved far more than I thought they would have, given that it's really only a 6 months and less picture, and there's a lot going on. But I think, David, I think the questions of non-execs are really helpful, really incisive. I think they're on the money, not to coin the phrase with Hugh on the video as well. But I think you know what the concerns are, you challenge us in the right areas, and it's anything, and everything really. So I'm not sure if that answers, but that would be my perspective as well.
Great, thanks Tracy. Diolch.
Mohammed, did you want to come in now with your final point?
Yeah, thank you very much, Jan. I mean, just on that previous conversation, I think it's going to be quite a challenge, isn't it? Because we're at an important transition point with lots of change about to happen, yet we have a tired workforce, and we have people who are probably ready for rest rather than change, and that's going to be quite a challenge for organisations, I suppose, like ours as well. But my point was about strategic risk, Jan. I mean, first of all, I'll repeat. I think there's been enormous progress with the way we present strategic risk, and the discussion we had earlier on strategic risk 1, I thought was a really good model for how we should be using the risk assessments. And I agree with Rianne that they are due now for a review. They're beginning to feel slightly out of date with sort of events and developments. But one of the things that we must improve, I believe, is the link between the identified risk and the expected impact of the identified actions. Right, so if you look at risk 2, that isn't working because we've clearly identified the risk. Almost none of the actions have been fully implemented, yet we're green or amber on our assessment of delivery. So that just doesn't add up. And it sort of suggests that we don't have to do any of those actions, and we might still have dealt with the risk. So there's still some work to do around making this more rigorous. I followed risk 1, and I think the other risks are pretty good as well, but risk 2 hasn't worked. I don't know whether it's worth trying to make it work or leave it for the wider review that Rhiannon talked about.
Yeah, can I respond? Is that okay? Thank you, Mohammed. I think actually we haven't even yet implemented the risk development plan. It's coming to the business executive team on Monday. So we've made some improvements ahead of that development plan, which of course we've engaged with you about, Mohammed, and other non-executive directors. So I think that plan should help us if we're in agreement with it. Some of it isn't a quick fix, but obviously the presentational elements are easier to fix than others. I'm just going to, I presume I can't see that Mark Bellis is on the call, because strategic risk 2 is obviously Mark. So I didn't know if Mark, you wanted to specifically speak to strategic risk 2 as it is yours. I didn't know if you want to respond directly to Mohammed's query.
Yeah, I mean, I take the point that we are at the beginning of responding to these things as we're coming, pandemic to endemic. I'd probably challenge, Mohammed, that many of these things aren't underway. Many of them are underway, actually. In terms of some of the earlier, they may be at earlier stages, but they are at least in activity. The reason it's green amber, I think, in part, and I think this is something that we need to review, is that we are, one of the things we've got to do is define the size of our role in this in the first place. we are predominantly facilitators in the public health of the nation, and therefore the risk needs to reflect our ability to facilitate, to support, advocate and help others, not necessarily represent the risk of a failure, if you like, of public health progress. I think that's difficulty. It's probably confused some of this, and maybe it is something we can come back to.
Thank you, Jan. I think, you know, I don't want to come back on that. I think that's probably as far as we can take it today, but yeah, coming back to it, good idea.
I think that most probably concludes, Jan, unless anybody's got any final questions. So back over to you. Thank you.
Thank you, Hugh, as ever, for steering us through that in that expert way. A lot of ground covered, and I hope that those observing us today will realise that the board does take all the material presented and then, as Hugh said, try to focus on those key overarching strategic issues and the big operational issues that are critical to the organisation's success. And Hugh, to you and the team and everyone involved in producing the report, and everybody's working so hard. And just to remind the board, if you remember at the November meeting, we did sort of approve the pack of information ready for the joint executive team. I know it was delayed then till January, but if you think even what we said had been achieved going in at that point is absolutely remarkable, given the fact we're still in the throes of the pandemic. So diolch yn fawr iawn i chi gyd. So gawn ni dorri nawr am goffi. Nôl mewn 15 munud, please. So we're going to have a break for coffee now. So can you come back at 15 minutes, which would take us to 11, would take us to 12, yes, adding that, take us to 15 on to 11:45. So back at 12, please. Okay, diolch yn fawr.
2-minute walk.
I've still got the adjourned for a short break on.
Yes, it's live on you.
Croeso nôl bawb, welcome back everyone, and we're resuming with a section of the agenda on reports from committees of the board. As I said at the beginning, the board does a lot of work through its committees, and every time the full board meets we have the opportunity to update ourselves. So Kate, you did report verbally at the November meeting on the meeting you'd had on the 10th of November. Now we have the summary of the key matters you discussed in written form. Is there anything you wanted to bring to the board's attention?
Yeah, thank you, Jan. Diolch yn fawr. Just 2 items really. So in addition to the usual reports that we take through quality, safety and improvement, we also ran a specific session on screening programme recovery, which I think has actually been covered already in this meeting by Meng. We also took assurance on winter planning for the organisation as well, including staff flu campaign rates. So I think those are probably the 2 things to bring to the board's attention, but also just to say we did also take the opportunity as a committee to do a bit of a reflection piece on the way in which we're using the integrated performance dashboard through the committee, and we're going to be trialling that for the Putting Things Right section in a couple of weeks at the next meeting. So I think that's everything from me. Diolch, Jan.
Yeah, Kate, thank you. That's a really good development there on to assist the work of the committee. So, diolch yn fawr. So, Sian, shall we turn to you, because we're delighted that correct knowledge, research and information has resumed. So, you had your first meeting on the 8th of December.
We did, Jan, thank you. Yes, we had our first meeting. We had it as a workshop type meeting so that people could put in their ideas for how to go forward, and Ian is the lead on exec for this, and we had another conversation yesterday about the next meeting. So we're going to be picking up the need to the development for the research and evaluation strategy, which we'll be bringing back to you, and we decided that we're going to do at the next meeting we'll be doing an update on the research mapping. So I think the first thing we're trying to do is to work out, we've got a name, we're knowledge, research and information, what does that actually mean, and what research is ongoing. So we're very grateful for the research mapping and people's participation in that at the moment. And we'll also be picking up some of the other issues around the global role that we discussed, that I mentioned a bit earlier. So yeah, good start, nice to start, and we'll be reporting back more formally on our next meeting next time.
Thank you, diolch, Sian. As you say, great, exciting agenda for 22-23 there.
Lots to do.
Yeah, pleased to have the committee back for such important work. David, the audit committee met on the 20th, so we don't have your written report yet, but I know that you wanted to bring to the full board's attention the structured assessment report. Anything else you want to highlight as well from last week's meeting?
Diolch yn fawr, Jan. Yes, as you say, we met a week ago, so just a couple of things to highlight, and we'll make sure there's a written report for the next meeting. We received a number of reports, particularly from internal audit, who were doing pieces of work around their particular concerns or programme of work, but also follow-up reports from items that still had issues outstanding. So there's a combination of reports, but in the middle of that, Jan, I just wanted to emphasise internal audit brought forward, I think 5 reports, 4 of which were scored as substantial. You're aware of the scoring they use, and they came back as substantial and 1 as reasonable. So really the in-depth work that internal audit has flagged up that in areas around recruitment, reactivation of screening services, which we mentioned quite a lot already this morning, the data breach that we looked at, additional hours in overtime, all those reports have come back giving us assurance as audit committee that things are on the right track, and indeed in many areas things are going very well. The structured assessment report was presented by Audit Wales, and we were in a position, Jan, to heap great praise on ourselves if we were able to do that, but more so perhaps on the leadership that has been over the last 12 months, 18 months around the governance of Public Health Wales, which is really reflected in the report by Audit Wales. And I have to say, I think that leadership you provided comes out clearly in the report around the governance that we have operated during this period. So the committee were really pleased that Audit Wales presented that report, and it just shows when things cause difficulty, when there is a crisis, that leadership comes to the fore, and I think that reflects very well on us as an organisation. So well done, and I think we should reflect in that praise when it's available. Diolch yn fawr iawn.
Diolch yn fawr, Meg. And I mean, to have the substantial sort of assurances from internal audit as well, it's really remarkable, given, you know, sort of the landscape as we have it across the organisation, as Tracy was outlining earlier. You know, this is coming up to 2 years of really, really tireless, hard slog on the part of all our staff. They are exhausted, but the fact that they sort of remain so committed and focused on doing the right thing and maintaining good governance is really phenomenal. So, Verity, I hope that you're still with us. And would you like to say something in respect of the structured assessment report, please?
Thank you, Jan. Just really to echo what David has already said, the structured assessment is our annual assurance work, and for as long as I can remember now, we've had really positive reports that look at operational planning, financial management and corporate governance arrangements. I remember last year you had a really positive report, and we were talking about this being an achievement despite the pressures of the pandemic, and how would you possibly follow it? Well, it's really positive to see that that has been sustained, and that is testament to the hard work of the people in this meeting and the whole organisation. So yes, you should be proud.
Yes, we are, and I'm sure the board is completely proud of all the staff that we have in Public Health Wales. And Verity, we're also appreciative of the very constructive working relationship we have with Audit Wales and with our internal auditors that really help us focus on improving all the time. And you know, I particularly am grateful for the support that you've given me during the year when I've asked you for various points of advice on maintaining good governance in these challenging times. So diolch yn fawr, Verity. So we don't have a report from our People and Organisational Development Committee because you meet in February, Mohammed and Neil, so we'll have a report at the March meeting. So diolch yn fawr to our committee chairs. So we move then to item 5.1, and as these minutes go out in draft form for people to comment on, we don't go through them page by page, but can I just check, are there any issues, please, in respect of the minutes of our meeting on the 25th of November last year? So I can take those and confirm them as the correct record. Diolch yn fawr. And then we have the action log And just wanted clarification there, Rhiannon and John. There are two where revised target dates are requested for the 31st of March 2022. Can we have a sense of the degree of confidence you have, please, that these will be delivered within that time frame?
Diolch, Jan. I don't know if John is still on the around the board. There he is. Hi, John. Yeah, John and I are actually due to meet because we will have to, I think, disaggregate elements of the risk around quality and improvement. Obviously, the timings of this have changed because there are discussions that have been held in the business executive team in terms of our organisational approach to quality more broadly. And obviously to allow the time to work out the detail in terms of what that shift will look like and how the governance will be handled. John and I need to have that one-to-one conversation, and we need some time, protected time, to do that. And I'm sure we'll find that soon, won't we, John? So I think it's more in that sense. And I think in terms of what it's saying in here, in terms of the revisions that we need to make on the actual, because at the moment there is only one risk that describes quite a large thing of sort of quality improvement. So I think we'll definitely be able to update for the next update requirements in terms of the timing. And yes, I'm confident that we will be able to do some of what we're saying in March, but the detail John will also need to identify as well.
Yeah, thanks. So John Bolton, National Director Quality Improvement Patient Safety. Just to echo what Rhiannon said, I'm confident that we'll hit the revised target date. There's also the intention that we'll bring an updated paper to board in March regarding the quality management system that we've been describing, the improvement hub and also innovation hub, with a clear plan.
Thank you. Thank you both. That's really, really helpful, and we look forward to that at the next meeting. So our last item then concerns items for noting, and I said at the start that this includes a new item this time in terms of a synopsis of our discussions in private board session on the 25th of November. The board will move into private session after we conclude this public meeting this morning, and that will be reflected in a similar report in March, and I will be refining that. We've also given for information the corporate risk register and papers associated with that. So I've not had any notification of items of any other business. So mae'n cyfarfod ar ben nawr. Dan ni'n neud hwyl am fawr I ein arsolwyr ar-lein. Diolch am eich amser bore yma. Cymerwch ofal a gweld chi at tro nesaf. So we'll say goodbye now to our observers online. Thank you very much for giving us your time this morning. Please stay safe, take care, and we'll see you next time. So diolch yn fawr I chi gyd am eich cyfraniadau. Thank you for all your contributions, board members. Cyfarfod da, it's been a very good meeting, and we'll say hwyl am nawr. Bye bye for now.